cure for diabetes has been quite evasive for an unreasonably long time because it's a metabolic disorder and so many factors play in the onset of diabetes. Till recently, bariatric surgery was considered a boon for obese type 2 diabetics in their never-ending saga of blood sugar control, weight gain, and diabetes-related complications. But now a new trend in surgical procedure is promising type 2 diabetics a solution to burden their blood sugar. We spoke to two metabolic surgeons at Hinduja Hospital Khar, Mumbai, which has a metabolic surgery clinic, to get a lowdown on this new technique which has been hailed by many medical experts as a cure for type 2 diabetes.
Bariatric surgery is used and aimed primarily at weight loss. And you have fringe benefits with control of blood sugar also, as also control of blood pressure, cholesterol, triglyceride, the other side effects and comorbidities associated with obesity.
Right.
Metabolic surgery is aimed at control and cure of diabetes. With that, if there is obesity, there will be a benefit in control of the excess weight, as also all the other comorbidities that go along with diabetes, including some complications that are early with complication on the kidney or the eyes which result from diabetes.
Okay. And how will this be different from that?
How will the metabolic surgery be different from
this
that?
particular?
The procedures are different. The metabolic surgery procedure, as I said, is aimed at control and cure of diabetes primarily.
Mm-hmm.
It's a bigger procedure than all the bariatric surgery operations. It is very specifically researched and aimed at improving different factors which are involved in the pathophysiology or the problems of diabetes, which arise from multiple areas of the body.
Okay.
This includes the intestinal tract, includes the liver, the pancreas, which is the primary area, includes the brain and the kidneys also. So it's a multifactorial say effect by which diabetes and its comorbidities get controlled, and the diabetes gets controlled in a much more effective way because it is addressing all the different aspects that lead to high blood sugar.
Okay, Dr. Ugale, so essentially what will be the site of this particular surgery?
Well, this is a laparoscopic surgery like any bariatric surgery. The procedure is done on the stomach, on the small intestine, and on the sympathetic nerves that supply the pancreas and the liver.
Oh, lovely. Okay. So essentially it will be to target the idea of controlling type 2 diabetes effects and costs.
So if one wants to simplify it, you need to improve insulin secretion in a person who has low insulin secretion from the pancreas. You need to make the insulin and the cells interact more effectively by removing insulin resistance so insulin can be used. And you need to reduce the glucagon hormone, which increases blood sugars and works against insulin.
Okay.
So when these three are looked at, you get a very smooth and effective control of diabetes.
Dr. Bharucha, that's an interesting aspect that we brought about, and I'm sure people might have a lot of questions on how this, the effects of this surgery would work. Can you tell us how does it really work in a diabetic?
So let's go back to your first question. You asked the difference between bariatric surgery and metabolic surgery. When bariatric surgery was introduced, it was only introduced for obesity. But we soon came to know that bariatric surgery, any bariatric surgery itself also has metabolic effects. Metabolic surgery is an offshoot of that there are metabolic effects of bariatric surgery, And that's how we started studying the effects of metabolic surgery and how we can transition from bariatric surgery to metabolic surgery, which is radically different from bariatric surgery. So actually, if you go to see, like you said that the surgery what we want to do, or what our aim is, the diabetics who are difficult to treat are the diabetics who are not overweight. Because if you are overweight or obese or severely obese, then it is very likely that your diabetes is following your obesity, or your diabetes is chasing your obesity. When you do bariatric surgery, you reduce the obesity, and that's how the diabetes reduces.
True, very true.
As soon as the obesity starts coming on, after the honeymoon period is over, say 1 year, 2 years, 3 years, your diabetes automatically starts increasing, and so do all the other metabolic syndrome factors also start going back from good to bad to worse as your obesity comes back. And no matter what bariatric surgery you do, after 2 years, 3 years, your obesity is going to come back to a certain percent.
Dr. Bharucha, it's very interesting because I have had even type 1 diabetics often tell me that just increasing by 5 kgs of weight can double the insulin intake.
Oh yes,
Double.
Oh yes, just simple weight loss in a type 1 diabetic will reduce the medication requirement even in a type 1 diabetic, because the diabetes is increasing only due to the obesity, or the morbidity of the obesity, which is the increase in diabetes, is directly proportional to the severity of the obesity. So whatever component is due to the obesity will reduce even in a type 1 diabetes.
So you mean to say that in type 2 also the same causes and effects work when it comes to obesity and the resistance of insulin?
Yes.
Resistance to insulin?
Yes, because an obese person will by themselves from the fat cells, they will release substances which promote diabetes. Okay. So these substances themselves promote diabetes. So reducing the obesity will also control the diabetes, or will reduce the diabetes.
Okay. So Dr. Ugale, can you also tell us about what kind of complications? Because as if I were type 2 diabetic and I wanted to go for this particular surgery, I would often ask myself what would be the complications, if at all, that would come post this surgery. What would be the complications? Are there any kind of particular things that diabetics have to be aware of?
Well, one aspect is that if one is undergoing surgery, one is undergoing anesthesia. So we'll leave the complications up, and yes. So one is during the surgery, one is following the surgery.
Okay.
So during the surgery is linked with anesthesia, linked with the surgery itself, with the procedure. Any of these surgeries, whether bariatric or metabolic, they use a lot of staplers and cartridges for dividing some parts of the intestine, for joining parts of the intestine. So potentially one can have bleeding, one can have leakage. These are the two main things. And in some people, post-surgery, you can have what is called internal herniation.
Oh.
Now, if good quality equipment is used and the judgment of the surgeon and the team are good, they will use the appropriate equipment and ensure that there is no bleeding, that there is no leakage. And when all these connections of the intestine are done, we close the spaces that get formed under it so that no internal herniation can happen. So this is to do with the procedure itself in surgery.
Okay.
Now, post-surgery, the inconvenience that a patient might experience in the beginning would be some intolerance to food.
Okay.
It could be for a few days or a few weeks or between 1 to 3 months. Different individuals have different phases of settling down. When the body gets used to the new system in place and they get acclimatized and settle down. And of course that one must remember, it's not only the procedure doing this, it is also the mental makeup and the attitude and the personality of the human being and the family support and environment that influences all this. Besides this intolerance of food, which fades away very soon, there is no other major complication that we see from this. Because in this procedure, we do not do bypass of the intestines. When bypasses are done, like in bariatric surgery, and if in bypass surgery, if the whole intestinal length is not measured, at times people may get a bypass that is more than they should have. That can lead to malabsorption, malnutrition, and many complications coming from that. So this procedure not having any bypass, you don't find any of these issues happening. Majority of them after 1 year do not need any supplements or medication, and they lead a completely normal and active life. And to give an example to the extent of that is a person that we had operated about 10 years ago, he has run 11 marathons in the US.
Wow.
Can be as good as that.
Ah, that's fantastic. Dr. Bharucha, yeah, you want to add something?
Yeah, I just to take this little bit forward, when Dr. Ugale said about internal herniation, what actually he meant was that there is an intestinal obstruction that can happen during the surgery if the defects of the curtain that holds your intestine to the abdominal wall, if those curtains they are not stitched together properly,
sure,
then you can have holes in between the curtains and the intestine can go in and cause an obstruction. Now this obstruction may be minor in degree or it may require another surgery just to treat the obstruction. So it can be even a major complication. The second thing I wanted to add was that when we are rearranging all these intestines so much, it is not the rearrangement of the intestines mechanically that is doing so much of the work or majority of the work. It is the hormones and the peptides and so many other things that are secreted which we really do not fully yet understand.
True.
We are looking at the phenomenal results that we are getting, even though we don't really understand the full mechanism, and I don't think anybody understands full mechanism of any surgery. You know that it's going to do this, but you mostly know the mechanical part.
Absolutely.
We don't, even the researchers really don't know exactly what are the hormonal effects, but the major hormone that is effective is the GLP-1 hormone, and this GLP-1 hormone, what it does is, one, it slows down the emptying of the food from the stomach into the intestine, which is the last part of the small intestine, which is brought right next to the stomach. So the part of the intestine which is used to getting digested food is today getting undigested food. So because of that, it releases certain hormones, of which GLP-1 is the major hormone, and which causes all these effects. Now GLP-1 acts on the stomach to reduce the gastric emptying or the time that is taken for the food to go from the stomach into the intestine. This also reduces the hunger that the patient may have, that the patient would have. So it will take care of an overweight diabetic patient or even an obese diabetic patient.
Okay.
The procedure also
You are essentially saying that this particular surgery can serve both the obese as well as the non-obese, the morbidly obese as well as the normal.
Yes, because
with normal weight diabetic type 2.
Yes, because the bariatric part of the procedure that we are doing is a sleeve gastrectomy. Now, why is a sleeve gastrectomy included? One is because we are removing a hormonal factor called ghrelin, which increases your hunger and comes from the fundus of the stomach.
Okay.
So we remove the fundus of the stomach, but we do not make the sleeve gastrectomy so tight that somebody who is not an obese diabetic will lose so much weight that he will have a problem due to the excess weight loss.
True.
So it is, so the sleeve gastrectomy, the size of the sleeve gastrectomy is dependent upon the BMI of the person. So we don't want the person to lose so much weight, but we also don't want the person to eat too much at one time when we are doing this rearrangement. Because then it would just cause a lot of after effects like nausea, etc. So the GLP-1 will increase the gastric emptying time. The GLP-1 will also increase the sensitivity of the beta cells of the pancreas to produce more insulin. So it is very important to have a pancreas that is responsive to produce insulin. If somebody comes who has already got diabetes for 20 or 30 years and the pancreas is almost burnt out and not producing enough insulin, then the results of the surgery are not going to be good. You cannot operate on a patient whose pancreas is not producing any insulin at all, because insulin has to be produced. And the other significant effect is that the peripheral resistance of the cells which are not taking the blood sugar into the cell through the effect of insulin, this resistance also is reduced, and the blood sugar can now go into the tissues where it is needed the most. The tissues are actually being starved of sugar.
True.
And the blood has got excess sugar. So both these mechanisms work, and because we are removing a part of the stomach, the satiety also becomes faster, and your craving for eating, foods that you should not be eating, even when you are a diabetic, you get this craving.
Absolutely.
Diabetics especially have a craving for sweet food.
Absolutely.
So all this sweet food or the processed food or etc., which is for which normally a person gets craving. You don't get craving to eat salad, or you don't get craving
Absolutely.
to eat something that
Absolutely.
you feel is not tasty.
Absolutely.
So all these things together are effective in the end result of giving a remission of 100% cure of your diabetes, or a good resolution in which even if your pancreas is not producing enough insulin, it is still producing enough insulin that it can be supported by, say, maybe one drug or two drugs, for your diabetes.
Okay. What has been the response of diabetics type 2 for this particular surgery in Hinduja Khar? Because you both are surgeons who are actually hands-on doing this particular surgery, performing the surgery for diabetics type 2, in terms of the success, in terms of how the procedure works, and in terms of how happy the patients are after the surgery. Can you tell us about that?
Sure. So the surgery is very successful, and one of the main reasons is, as Dr. Bharucha mentioned earlier, that we would do some tests to check and ensure that the pancreas is responsive. These are some blood tests that we would do, check some levels of insulin and C-peptide. And once we know that the pancreas is responsive, we are sure that the surgery is going to be successful. Because the procedure works via the pancreas, when we are relying on natural insulin that is secreted by the pancreas, and the control of glucagon, the opposite hormone, that also is secreted by the pancreas.
Okay.
So this assessment ensures this success.
Correct.
So
Okay.
we have success in all our patients because we have selected them, chosen them, and we know it's going to be successful. Now,
Is there a particular criteria for this surgery that the diabetics should know before they approach you?
the reality is that it is better, what is more practical is it's better for a diabetic to come and visit us in the clinic, because then we take a detailed history, we do some tests, and then we can advise them accordingly. Because if somebody has got diabetes just 1 month ago and has got mild diabetes, we don't want to advise them surgery. We would say, please do your part. You have a certain accountability to your own self. So do your diet control, do your exercise, learn to control the mind, avoid restlessness of the mind, do whatever yoga, pranayama, meditation, and if some medication is required, you may be on 1 pill or 2 pills.
Absolutely.
And if a person is stable with that, they don't need surgery. So we'd be able to assess all these things. Now, if we find that in spite of doing all the right things, or their lifestyle situations are such that they are not able to maintain a regularity in their lifestyle, sometimes work and travel and the environment brings about its own sort of challenges.
Okay.
In which case, if you find that in spite of doing whatever they can do, the diabetes is going on increasing, medication is going on increasing, they may come to a stage where insulin has to start. Some are on insulin and the insulin is going on increasing, and we've had patients going up to 300 units of insulin per day. Yet, sugars are not under control because the body then becomes resistant. So, if or at times the sugars are under control because the HbA1c, the 3-month average of the sugars, is reasonably under control.
And what according to you is the reasonable, because every doctor, diabetologist has
Yes,
a different.
I would say in a practical sense, what is sensible for society would be a figure of 7 or less. Would be fine, because ideally it's supposed to be 6% and less. 6.5% is still very good.
Uh-huh.
And I would say that up to 7 would be okay, but they must do their own bit also with that. If it goes on increasing above that, then of course they have to re-look at their treatment and their approach. Now, at times these are under reasonable amount of control, but some complications are starting and they are in the early phase. Like you have protein leakage from the kidney, or you have complication on the eyes and retinopathy starts, but it's in the early phase. Now, many times diabetics do not look at these factors and they get missed until it becomes severe, when it's of no use to anyone. If these are in the early phase, even if the diabetes is relatively under control, we would suggest operation, because that means we would be able to reverse these complications which are in the early phase. Even when it goes in the moderate zone, but it's the early phase of moderate, we can still reverse these complications by surgery. But once it crosses that and becomes severe, then I would recommend to those patients, yes, we can control your sugars, but we cannot save your kidneys or your eyes, so maybe operation is not the best way to go ahead.
Golden words. Absolutely right. Bharat. Yes, you want to add something to it?
Yeah, see, when you say criteria, I think of two different things. The criteria for the patient and the criteria for me. If I'm talking to you as a patient with type 2 diabetes, I would tell you, if you have difficult diabetes, that means if you have distress,
Okay.
if you have stress, managing your diabetes from day to day, you have to check your blood sugars many times in the day because your blood sugars are fluctuating. If this is giving you distress, this is coming in the way of your day-to-day life, in the way of your day-to-day activities, then come early to the metabolic surgery clinic, because we will assess you. now from you as a type 2 diabetic, I am shifting to me. So for you, it's very simple. Difficult diabetes, distress in managing your diabetes because of fluctuations in your blood sugar which cannot be easily controlled. That is the only criteria that you need to keep in mind as a patient. As somebody who's treating the diabetes, when you come to the metabolic surgery clinic, the first thing that we do after taking your basic history and finding out how bad is your diabetes, since how long you have your diabetes, at what stage of your type 2 diabetes you've come, what are the other comorbidities or other problems that you have along with the diabetes. We will evaluate you. Now Dr. Ugale himself has devised a very good scoring system which is called the diabetes remission score. This scoring system actually has certain points which you give to certain factors, to specific factors in the of the patient.
Okay.
So according to this score, I will tell you very simply, the higher the score, the better your chances of getting a remission. The lower your score, the poorer your chances of getting remission. So I would actually encourage somebody who has difficult diabetes to come to the clinic early so that we can tell you that whether the surgical solution is better for you or will work for you or will not work for you, or how much it will work.
Just to interrupt you, there are multiple scoring systems in the world. We are the first ones to suggest a diabetes severity and remission score so that you can assess whether somebody's diabetes is mild or moderate or severe and accordingly choose the treatment.
So what are the parameters in this particular scoring system that you have?
So in our scoring system, we have 8 factors which are age, the BMI of the patient, the duration of diabetes, whether they are on mandatory insulin or not, whether they have got complications which we call microvascular, that is to do with the nerves or the eyes or the kidneys, or macrovascular, which is to do with the heart or blood vessels or the brain, strokes and such. And we look at the HbA1c, and we also look at the stimulated C-peptide. That's looking at the pancreatic response. So these are the factors we use. But as Dr. Bharucha was saying, some of the scoring systems, when it's a higher score, it's more favorable.
Okay.
In our scoring system, when it's a lower score, it's more favorable. So the lower score is mild or moderate, and the higher score is severe. When the score is very high, we can give the prognosis to a patient and their family prior to surgery. So we can tell them that your diabetes is so severe and your pancreatic response is, let's say, lukewarm and not very good, so you are likely to have only a partial result or control from this surgery. And if somebody's score is favorable, we can be sure, we say, you'll be able to get rid of all the drugs, get back to normal life, be able to eat everything in limits, in moderation. We advise everyone live in moderation, but be free of all drugs and get rid of any complications that are starting.
Dr. Bharucha, very interesting points that he has raised. How different do Indians react to this particular surgery if you compare them with the Western world? Because diabetes is a very typical situation where West is a different animal altogether and our country is very different.
I think the first thing that comes to my mind is that naturally in the Western population you will find diabetes secondary to obesity. Much more common than just having plain diabetes, which is type 2 diabetes, not type 1 diabetes.
True.
You would hardly find anybody who is a type 2 diabetic who isn't obese.
I see.
So for such a person, that's the main difference. So Here you would see quite a lot, maybe 30-40% of patients coming who are lean diabetics, whereas there you would hardly see not even 15 or 20% of patients coming who are lean diabetics but are obese diabetics, and who will benefit by bariatric surgery.
Yeah, so when you look at figures, the data which is there, global information and data, as Dr. Bharucha said rightly, in the Western world, there is 80% of the people are obese and diabetic, while only say 20% would be non-obese diabetics. In India, we find from our data that about 65% are non-obese diabetics and the rest are obese diabetics. So when you look at that, you realize that you need better controlling factors for our Asian patients or Indians, because when they are non-obese, your procedure or your treatment has to be a lot more effective to fix either low insulin secretion or the insulin resistance or high glucagon that goes along with it. So it is easier in the Western world to do a bariatric procedure and get a control of the diabetes also, while in Indians you need a better procedure, and that's why this procedure of duodenal ileal interpolation is more suited, because majority are non-obese diabetics.
Essentially, the fat in the stomach area.
No, it's also a lot to do with the diet. See, our Indian diet is mostly carbohydrate based diet, and today we all talk about carbohydrate as, carbohydrate is almost a bad word, which is mainly responsible for giving us Asians excess central obesity for the same BMI that would be there in the Western counterpart. That is why the criteria for selection for a patient for surgery, for metabolic surgery or for bariatric surgery, is much lower, than the criteria for selection for a patient for the same surgery in the West or a Caucasian. Like you can take for example that anybody with a BMI of more than 30 would be surgery would be considered as a treatment option for that patient, whereas in an Asian population we take 27.5 BMI as taking into surgery into consideration as a treatment option.
Okay, so let me come to the most important issue, that is the cost of this particular surgery. How much would it, an Indian, if they approach you, how much will it cost for this particular surgery to bring this diabetes under control?
So this, to give an approximate estimate, is about 6.5 lakhs in a twin sharing room, and then depending if a person chooses higher grades of rooms, then the charges would increase accordingly.
So is there a period of quarantine also after the surgery?
You mean of bed rest and isolation? Yeah. No, that's not required, because we want everyone to be active. These are laparoscopic surgeries, and the person is walking either the same day or the next day.
Oh, wow.
So they are allowed to move around, they are allowed to climb stairs, they are allowed to move around the house, get back to work. In fact, we encourage them that somewhere between 7 to 10 days after surgery, they should be able to get back to work. And after 1 month, they can do any activities, sports, gym, swimming, anything after 1 month of the surgery.
Of the insurance companies in covering patients for this surgery, for metabolic surgery.
Okay.
Because till now, bariatric surgery was considered to be just a cosmetic procedure, or it came under that heading of cosmetic surgery. Okay. That you just wanted to lose weight to look good or something like that.
Unfairly. They are unfairly put under that.
Very unfairly. Yeah. Because unfortunately, I don't know, they don't realize or they did not realize till now that just by doing a bariatric procedure, an insurance company can save so much money in the future.
On the complication, treatment of the complications that arise from that.
So you won't need a kidney transplant, you won't need extensive eye surgery, you will not need extensive cardiovascular surgery.
Yeah.
So all these things that can be prevented, they are now waking up to that fact that yes, we can save a lot of money. The same way that if we can give a good remission to the diabetes, we can give complete remission to diabetes or a good resolution of the diabetes now, then, and I can give you a diabetes free life for 10 years or so, then your development of complications or your return of your diabetes also, I mean, the chance is very less, but even if you're unfortunate and the diabetes does come back because primarily your beta cells are not responding or producing enough insulin, then your requirement of your drug dosage is less, your chance of getting complications is less, and the chance of you going for further complicated, expensive treatment for all this is much less, and you're getting a 10-year diabetes-free life, which is delaying your complications of diabetes also by another 10 years.
So this is for people who've come at a moderate or a later stage. For people who come earlier, the diabetes-free situation should be lifelong. It would be lifelong. Now, contrary to the attitude of the insurance firms here, it was interesting to note how we had a patient from New Zealand. This was about 10 years ago. His insurance firm said to him that if you get rid of your diabetes, we will cover all your expenses, because they are looking at long term.